air pollution in Delhi improved?
Yeah, it's slightly better than during those times, Ancon time. And generally, we had a few sunny days last week. And I think the stubble burning has also decreased in and around Delhi. So I think it has improved, definitely. So if we are ready, then
sir, I opened the room, so you can
right.
start.
So with the permission of the president, can I begin?
Yes, please. Yes, please.
Right.
Thank you.
So good afternoon. Good afternoon, everybody. I welcome to this Indian Academy of Neurology Headache Subsection webinar. So first of all, I congratulate and give our sincere thanks to our new president, Professor Gagandeep Singh. And thank you, sir, for joining this webinar. And I think after assuming presidency, this is your first webinar you are joining, or you have joined some other webinar also? I don't know.
This is indeed the first. And congrats to you too, Dr. Debashish, for becoming the president-elect and the future president. and also secondly, for unfailingly holding this webinar, which is, I think, on this exciting topic, headache, which is between you and me, and probably this is a newfound interest for me, and particularly the relationship between a condition in which I was very passionate about, but then my newfound passion is the interrelationship between headache and epilepsy. So I'm looking forward to this.
Correct. So that's great news for us. And when President of Indian Academy of Neurology is interested in headache, and especially the border zone and borderline between headache and epilepsy, then it becomes all the more interesting. And I also welcome Professor Gautam Ganguly, who is now currently the chair, has assumed the responsibility of the chair. But today they have an Anicon meeting there, and just now he told me that there is going to be a general body meeting there, and he has to be there. So Dr. Ganguly, Professor Ganguly, are you there still, or you have left?
I have to, because I am the president of any this year.
Okay.
That is why this is the meeting. So it is even also because this boy, he is also chairperson. So if you permission me, then it will be
no, sure. I can,
yeah,
sure.
Because of the
yeah. I can understand that you are still in the hotel, I think, in that hotel where this is happening. So it is breaking also the voice in between. So I definitely thank you for taking up this responsibility, and also that in future meetings, I think we will be having more interaction.
Definitely.
And with the support of the.
I shall miss this exciting case, the discussion that will be the, because like Gagandeep, I am also very fascinating subject. So headache with epilepsy, this is where interrelations is there. And because I myself suffering from epilepsy, and I have had an attack as a headache followed by a convulsion. That is the thing. I remember the headache. Later on, convulsion by my residents described this thing. So I missed this session today. With your kind permission, if I now
Yes,
leave
sir.
this webinar.
Yes, sir. Thank you so much for joining, even for a short time, and we will keep you updated for all the activities. And Dr.
Definitely, I will be for the next meeting onwards. There will be no problem. I will be there.
Right. Thank you. Thank you so much, sir.
Okay,
so Ashish, are you there, Dr. Ashish? Hello, Dr. Ashish, are you there?
Yes, sir, I am here, sir. Good afternoon, good evening, sir.
Good evening, Dr. Ashish. So first of all, I think you should introduce the first speaker, Dr. Kamakshi Dhameja, and she can then give a brief introduction and she can start with the case.
So, good evening, everybody, and welcome to this headache subsection webinar. And the first case will be presented by Dr. Kamakshi Damija. She is Assistant Professor of Neurology at VMC and Subsection Hospital, New Delhi, and an alumni of GB Pant Hospital. And she will be presenting an agonizing touch. Can something calm me down? So, Dr. Kamakshi, can please start sharing your slides.
Thank you, sir, for the kind introduction. I'll start sharing my screen. Yeah. So, starting my case. So this was a 56-year-old female who had this headache from around 2 years. This headache, she had been heading from the last 2 years. That was right side locked headaches, but now for the first time, she presented with a severe headache in emergency to us, where we saw her for the first time. So there was a background history of these 2 years headache. We look into the characters of this background headaches, which she had been having from last 2 years, which were right side locked, excruciatingly severe headaches. The character which she used to describe was a sudden shock-like stabbing character of headaches, at times burning. She would rate around this to be around 9 on 10 on VAS scale. Location to be infraorbital and cheek area, occasionally radiating to the jaw and occasional temple area. So the average headache frequency would be daily, 8 to 10 attacks per day. So it would occur in this sawtooth pattern, as you can all see. It would occur as if it would occur, then come down a bit, then occur again, then come down a bit. So this total sawtooth pattern would occur approximately for 5 minutes before touching the baseline. So this headache would occur at times spontaneous, but it would be triggered also, and the approximate spontaneous to triggered attack ratio was around 3:2. The triggers which she could identify were speaking, attempting to swallow, chewing, touching some areas of face like nose or cheek. However, immediately after getting the attack, these triggers could not induce further attacks. That is, there was some evidence of at least historic evidence of some refractory period after the attack. It was not associated with any nausea or vomiting. In nearly what she could recall, in nearly 50% of the attack, there were some autonomic features in the form of watering from the right eye and some redness of the same eye, and watering from the nose during the attacks. However, there were no circadian or seasonal periodicity for the same. Previously, she had been given carbamazepine around 1200 mg per day with partial relief in the form of, like she used to get when she was put on this treatment, around 1 to 2 attacks in nearly 2 days. And with this therapy, there were no triggered attacks. She intermittently defaulted on treatment, however, remained well by doing so. And presently, she was not in any treatment. She carried around 1.5 Tesla MR brain films with her, and including a CIS protocol, and this was normal. So the crux of the story was, she was a 56-year-old female with 2 years history of neuralgiform headaches in right V2 distribution, multiple attacks a day, both spontaneous and triggered, each attack lasting approximately 3 to 5 minutes in a sawtooth pattern, associated with ipsilateral autonomic symptoms, and history suggestive of refractory period after the attacks, and a good relief with carbamazepine. So our first diagnostic possibility was trigeminal neuralgia, as ICHD-3 also defines this entity as recurrent paroxysm of unilateral facial pain in distribution of one or more divisions of trigeminal nerve. And usually the pain which the ICHD-3 defines is, it lasts for a fraction of seconds to 2 minutes. It's of severe intensity, electric shock-like, can be shooting, stabbing, or sharp in quantity, and it is precipitated by innocuous stimuli within the effective trigeminal distribution. So the odd points in our case was the attack duration was longer, and there was some ipsilateral autonomic symptoms associated with the pain. The second possibility which we kept was a short-lasting unilateral neurologiform headache. So ICHD-3 defines this headache as they are moderate to severe intensity headache that is located in the orbital, supraorbital, temporal, or other trigeminal distribution, can last for around 1 to 600 seconds and usually occur either as in single stabs, a series of stabs, or in sawtooth pattern, and is associated with at least one of the following cranial autonomic symptoms or sign, which is ipsilateral to the pain and can be in the form of conjunctival injection or lacrimation, nasal congestion, eyelid edema, forehead and facial sweating, forehead and facial flushing, a sense of oral fullness, and meiosis and ptosis, and occurs at the frequency of at least once a day. So the points in favor of this headache was she had obviously a sawtooth pattern of pain. The attacks, the duration of attack was relatively longer, like in our case, it was 3 to 5 minutes, and there was some evidence of autonomic symptoms historically. But in our patient, it was majorly limited to V2 distribution, although it did not negate the presence of this short-lasting unilateral neurology from headaches, because V2 distribution is reported in a handsome percentage of patient also. But the presence of refractory period historically went against this entity. So we looked into the attack duration and the autonomic symptoms in trigeminal neuralgia. So the ICHD3 puts a footnote that the duration of trigeminal neuralgia can change over time and the paroxysms can become more prolonged. And a minority of patients can report attacks which can last around more than 2 minutes also. And mild autonomic symptoms such as lacrimation and redness of the ellipsoidal eye may be present in the attacks. There was this paper, it actually looked into the objective assessment of the autonomic signs during the trigeminal neuralgia. And it mentioned that as the duration of the trigeminal neuralgia went longer, it may be associated with some autonomic signs. And it is actually not just the presence of autonomic signs which differentiates the SUNCT or the versus the trigeminal neuralgia, but it is the degree of the autonomic signs which differentiates both the entities. So the longer the attacks, it can be associated with autonomic symptoms as well. So historically, we did not consider at this time a diagnostic possibility of attacks in this patient. So our first differential was trigeminal neuralgia only with possible autonomic features because there was some longer duration and we didn't have a video of the baseline ictus also with us. So now, when we first time saw the patient, all this time the patient had not visited us. For the first time when she now landed to us in emergency, this was the video of the attack, which I would like to share with you.
आंटी कितनी देर से परेशानी है आपको?
तो परेशानी ऑपरेशन है जो
कितने टाइम से ज्यादा हो रही है?
सुबह से
सुबह से कहाँ दर्द है? हाथ लगा के बताओ। कितनी बार हो गया सुबह से ये?
7 बजे का हो रहा गाना।
कितनी बार लगभग गिनती है इसकी?
गिनती नहीं।
कैसा दर्द कैसा होता है ये?
जलन सा हो रहा है कतियाड़े कन्यों का सुता जन तो रात पके आकरन्यों।
अच्छा एक बार आँख खोलो, आँख खोलो। किस किस चीज से दर्द हो जाता है आपको?
नाक का थला झाड़ा जो दर्द हो जा, आड़ा थला जो दर्द हो है।
So now this lady had been having this severe intensity of the pain since last 4 hours, unremitting, no refractory period, unilateral. The brunt of the pain was in this V2 distribution. The lady was not able to even touch the side of the nose or to the lip. And as we can all see, there was
कितनी देर से परेशानी है आपको?
So more than 4 hours of continuous pain, the brunt of territory was in V2, and cutaneous triggers, as we all know, as is evident by the video, they were clearly evident and there was no refractory period. Also, this eyelid edema, the facial edema, and the autonomic features in the form of right eye, some redness and lacrimation were evident. So now the dilemma was whether we were dealing with a case of a status like SUNT from the last 4 hours. The patient had been having an unremitting type of severe excruciating headache with ipsilateral autonomic features, or it was a status of trigeminal neuralgia with ipsilateral autonomic features. So definition wise, a SUNT status is considered to be present when fully developed painful attacks have been occurring with such a high frequency, which numerically has been counted more than 30 attacks per hour, and they have been so enormous that they persist for the better part of the day. So getting by this definition, although the patient had been having such an enormous paroxysm from morning, that is around 4 hours, categorically she didn't fit, but yes, if the attack was allowed to go on for long, she might fit into this. Secondly, likely we kept our possibility to be our trigeminal neuralgia SUNT overlap it could be a background trigeminal neuralgia which could have now possibly evolved into a SUNC-like disorder. And presently we were dealing into an acute SUNC status. So treatment response, as we all know, with carbamazepine is known in SUNC2. And this time there was no refractory period, as is evident now, between the frequent attacks. So what we could do now? So given the continuous pain in this V2 territory with significant cutaneous sensitivity, presence of autonomic features, and the lack of refractory period, we treated the patients on line of SUNC status. So the treatment options in SUNC status, as we all know, the first line of treatment includes the lamotrigine. Second line status includes the oxcarbazepine, topiramate, duloxetine. The third line includes the other agents, but all these, they take time to work. They need escalation and they won't work in such an acute situation. Transitional treatments in the form of IV lidocaine, GON blocks, and oral and IV steroids are available. But our patient, this was a paper which mentioned that SUNC and SUNA, it's responsive to IV lidocaine also. But in our patient, we had an issue that her baseline ECG showed a second degree heart block, which is clear contraindication to IV lidocaine use. As far as oral and IV steroids were concerned, she was a known diabetic on insulin therapy, poorly controlled. So we were not comfortable in using this also. GON block was a valid option, but an emergent relief in such a situation when the patient came to us crying in pain, something had to be done for this immediate relief. So what to do now? So after a team discussion with our pain and neuroanesthetic team, we headed forward for the local sphenopalatine ganglion blockade. So our patient was given a bilateral SPG blockade with 2% lidocaine, which resulted in around 7 to 8 point relief on VAS scale. So how is this SPG blockage done? So patient is basically explained all the procedures. This procedure is done in a recumbent position with the neck extended. We gave the patient some lignocaine jelly to be applied liberally into the both nostrils, and the patient herself inserted the jelly through his own finger, positioned in supine extended position. Ideally, it is done through a SphenoCAD device, but in resource limited settings where the SphenoCAD device is not available, we can use a throat swab also, and it is inserted through the anterior nares till the point of maximum insertion where we get the resistance. Until that point, after inserting the throat swab through the inner tube, which we position the tube, and through this inner tube, we instill around 2 ml of 2% lignocaine in each of the nostrils. And in that position, the patient is kept for around 10 minutes. So there have been many papers onto the sphenopalatine ganglion blockage, and its role has been discussed in many primary headache disorders. And why its role is being discussed is because sphenopalatine ganglion is a large parasympathetic ganglion, and it has multiple neural connections, including autonomic, motor, and sensory connections. It is located deep into the pterygopalatine fossa, and given it's a reasonable target to help relief in pain and autonomic features commonly seen in primary headache disorders, especially when it comes to migraine. So activation of the brain areas where it is related to the superior salivatory nucleus, it leads to the stimulation of trigeminal autonomic reflex, which results in increased parasympathetic output from the SPG. So causing the blockage at this level, it results in blockage of the parasympathetic activation and mitigation of the headache. Similarly, this is one mechanism. The second mechanism, it leads onto the effect on the central sensitivity and the modulation of the central sensory processes in the trigeminal nucleus caudalis in the efferent sensory fibers itself. So it may modulate the central pain processing mechanism and reduce the central sensitization to the pain that is so commonly seen in migraine also. So this is the video of 30 minutes post block.
10 में से कितना पैसे आराम होगा आंटी आपको?
8-7 हुआ है.
So 30 minutes post block, there was much significant relief in her headache now.
10 में से कितना पैसे आराम होगा?
So further on, the patient was initiated on lamotrigine around 25 mg per day and increased to 50 mg twice daily, which resulted in substantial relief to around 2 to 3 attacks per week. So tic-tac overlap is well known in other trigeminal autonomic cephalgias like cluster headaches and paroxysmal hemicranias, and there have been reports of its association in short-lasting unilateral neuralgic headaches also. As we can see, multiple case reports have been published in for patients overlapping with cluster and tick syndrome. And ICSD-3 also says that if a patient, all the more cluster and tick, they are rare disorders, and clubbing and diagnosing both the disorders in one patient itself is rare. But if we diagnose the patients with both these syndromes, the treatment for both the disorders should be initiated in order for the patient to get completely pain-free. So it's important to diagnose both the conditions if they have been concomitantly existing. Similarly, this cluster tick syndrome and paroxysmal hemicrania tick syndrome, the case reports have been repeatedly published. As far as the SUNC syndrome is concerned, there have been recurrent repercussions, whether it's a trigeminal neuralgia with lacrimation or a SUNC syndrome. So what the common consensus has come up is SUNC is a relatively longer pain, and trigeminal neuralgia has relatively shorter pain. So trigeminal neuralgia, shorter pain, lesser autonomic features may be there. SUNC is a relatively longer pain syndrome, so autonomic features are profound. So basically, it is not just the presence of autonomic and the cranial autonomic activation which differentiates, it's the degree of the autonomic activation which can differentiate between the two disorders. Although, because there is much overlap between the syndromes, there can be a pathophysiological link between these two entities. So this paper, it actually summarized the differences and clinical points between the differentiation, how to differentiate between these two entities. So as we all know, trigeminal neuralgia is much more common in V2, V3 territories as compared to V1. However, SUNC and SUNA are commoner in V1 territories. However, V2, V3 territories, SUNC and SUNA are also seen. V2, V3 territories, SUNC and SUNA are seen in around 70-75% of the patients, and V3 SUNC is seen around 30% of the patients, and V3 SUNA in around 30-40% of the patients. And there may be radiation even to the cervical branches also. Also, what characterizes SUNC and SUNA disorders is a single stab, group of stabs on the sawtooth pattern, which is usually not a characteristic of trigeminal neuralgia. Trigeminal neuralgia is a shorter lasting pain disorder, lasting for around 2 minutes. SUNC SUNA usually lasts longer, for around 600 seconds. Both spontaneous and trigger attacks are characteristic of SUNC SUNA disorders. It is very important to remember that the presence of refractory period is classical for trigeminal neuralgia, where it is usually not seen in SUNC and SUNA disorders. So as far as autonomic symptoms are concerned, the autonomic symptoms usually are not a part of trigeminal neuralgia syndrome. However, for the longer and more severe attacks, they can be seen, whereas by definition, they are present in SUNC and SUNA. As far as effect of carbamazepine is concerned, around 70 to 100%, 98% of the patients respond to trigeminal neuralgia, they respond to carbamazepine, whereas less than 1/3 of the patients respond to carbamazepine in case of SUNC and SUNA. So this was an interesting case wherein the authors have described a patient over the longitudinal years in which the patient initially had a diagnosis of trigeminal neuralgia. Over the years, developed over a combination of syndrome of both trigeminal neuralgia and SUNC, and later on, he developed an exclusive symptomatology and fitted exclusively into a SUNC syndrome. So what we want to emphasize is both the headache disorder, this short-lasting unilateral neurologiform headaches, and the trigeminal neuralgia, they have a neurologiform character of pain. Both have a the attacks are brief, multiple attacks per day. Cutaneous triggers can be evident in both. Autonomic features, they are proportional to the duration of attacks. And ICHD, it mentions an entity of trigeminal neuralgia with concomitant persistent facial pain also. And report says that there have been evidences of neurovascular conflict in the SUNA case reports also. So both the entities can be pathophysiologically linked. They are more similar rather than different. Thank you for your attention.
Thank you, Dr. Kamakshi, for a very lucid presentation and elaboration about the literature behind it.
Thank you, sir.
So I will request all the attending delegates to put their questions in the question answer box so that we can discuss them. I have 3 questions which are probably not directly related to your case, but we'll take them up by Dr. Surendra. But anybody want to talk about this case first? Put up some questions on this based on this case, or want to share their experience on status like SUNT or status like SUNA and the management that has been offered.
Very nice, Kamakshi. Thank you for the case and
Thank you, sir.
very informative. So tell me, I mean, the question that I have is, why did you think of giving a block bilaterally, rather than
Yes,
just
sir.
on one side? Is there
Yes, sir.
some rational or some theoretical basis for that?
So as the peripheral nerve blocks are concerned, for example, Gone blocks are so frequently used in migraine headache disorders nowadays.
Yeah.
So even in the patients who have unilateral headaches, if we check for the tenderness of Gone points, bilateral Gone tenderness is well known. And bilateral Gone, as we this bilateral blocks, when we apply, they more of on a pathophysiological basis, they lead on to a central modulation of the pain pathways. So literature says, so more than acting peripherally, they may actually alter the central sensory nociceptive pathways. So it may be useful to give bilateral blocks rather than unilateral blocks. Although one paper, it actually had looked into unilateral versus bilateral Gone blocks and mentioned that unilateral unilateral might be non-inferior to unilateral blocks also. But as far as pathophysiological basis is concerned, because it may alter the central sensory nociceptive pathways, giving bilateral may be more rational, I think. The rest, I think, Devashish might elaborate more on this.
Right. Thank you. Thank you.
Yes, sir.
Yeah, I think you have answered that well. But the point is this, that this side-locked headaches like cluster headache or Sancton Suna, one can consider, because they are strictly side-locked, so they do not change time. One can consider unilateral blocks also. But for as far as the Gone block is concerned, it is generally it is preferred to give bilateral, is because that at the back of the neck, there is a convergence of cervical and the spinal neurons. So that happen bilaterally. So there's a bilateral exchange. And when you are modulating this pathway, if you modulate just one side and leave the other side open, so that might cause problem. And there have been case reports in cluster headache when you have put unilateral Gone blocks, the cluster has returned to the other side, the other eye. So there are reports like that on few also over a period of time. So therefore, it makes a sense. I mean, I'm not so sure about that how much the bilateral sphenopalatine block will work in this case, but generally it has been safe. Although I must admit that as far as the scientific literature and the evidence is there, it is not so robust yet. So it has, because last time when we did the review, we tried to find out that we of course for cluster headache, the sphenopalatine ganglion stimulation by putting a chip into the sphenopalatine ganglion and stimulating externally, that has got a robust evidence base now, and that has been approved by FDA also. So that is there, but as far as the block is concerned, that is yet to come out through a major study. So that's the thing. But in a given case, yes. And one thing, Kamakshi, I would say that even in acute setting also, you can give Gone blocks, because Gone blocks have been shown to decrease the pain severity as an immediate effect also, in addition to this modulation. So many patients do after 30 minutes to about 24 hours, they do have a significant decrease in pain intensity. Was on Gone block.
Fine.
So, and so there are a few questions which I would like to throw it to the panelists. That one question by Dr. Surendra is this, that he saw a patient, 45-year chronic smoker, male, who had a new onset right hemicranial headache for 5 days. No focal deficits, fundus normal, NCCT head normal, but ESR is 60. So what's your comment? So Dr. Kamakshi, Dr. Gagandeep, any idea, any comments on that? So he is a chronic smoker, and obviously chronic smoker raises, as 45 years raises specter of, he was a side-locked hemicranial headache And if it fulfills other criteria of cluster, then obviously one can think of a cluster if it's occurring in a cluster. But just a right hemicranial headache doesn't actually, you have to give more, kind of data or details for that. But the ESR 60 needs to be investigated. And sometimes there's in patients who are around that area, around that age, 45 to 50, I think temporal arteritis should be a concern for all of us. And we should actually, see that. Anything you would like to add? Any other panelists? Okay. So that is on question one. Secondly, Dr. Kamakshi, did you see any positional and cluster-like headaches in isolated middle cerebral artery dissections?
I had a patient of one ICA dissection who had presented with an acute cluster-like headache, but not in an MCA dissection.
Right.
ICA dissection, I had a patient, sir. But
Yes.
not.
So ICA dissection is a common, differential in DD of a acute onset facial pain or cluster-like headache. I don't know about the positional part because I haven't really recollect having seen a positional headache. I mean, I probably think that he means a postural headache, orthostatic headache, but I have not seen an orthostatic headache presenting because of isolated middle cerebral artery dissection. But anyway, the middle cerebral artery dissections are not that common compared to the ICA dissections. So yes, ICA dissections, and especially if they're happening in and around the cavernous sinus, so all the pathologies in and around cavernous sinus can produce lichen cluster headache or attacks. So one has to be very careful, especially if the pain is a very acute onset, suddenly has appeared and out of the blue, and there is an associated Horner syndrome with a facial pain. So you must think of a ICA dissection. So that is, one question. Dr. Chandrasekhar is asking, is there any role of surgical management in the treatment of Sankt and Suna? Dr. Kamakshi.
So surgical one is this micro, like as we have already discussed, this phenopalatine, this modulation. One is this. So then there is since the basic pathophysiology revolves around this posterior hypothalamic gray matter dysfunction. So this hypothalamic brain stimulation has been explored in the role of this Sankt and Suna management also.
Right. So I think that first of all, you need to find out, is there any neurovascular conflict? Because about 30 to 40% of patients may have a concurrent neurovascular conflict, just like a trigeminal neuralgia. So if that is there, and if they are refractory to medical treatment, then you can go ahead and do a microvascular decompression as suggested. There has been also, some papers which are talking about the radiofrequency ablation or radiofrequency ablation of the sphenopalatine ganglion for a refractory cluster headache as well as Sankt and Suna. So, but those cases are rare and anecdotal. By and large, you need to stick on the medical treatment, and generally what I've suggests that if you do the medical treatment correctly, the patients do improve. And I would add to whatever you said about the distinction. I saw that table which you have shown to us from our paper, but I think lately I have realized this fact that if you are finding a case of trigeminal neuralgia, suspected trigeminal neuralgia diagnosed, a lot of people come to you as a follow-up also, right? Then you don't ask the details about that in great detail, right? So, but they are refractory to your management. It happens about 25-30% patients who are not at all getting, or initially they're getting some response to carbamazepine and then the effect stops. So in those patients, you must suspect that is there any, Sankt and Suna, is not trigeminal neuralgia, or the trigeminal neuralgia has now shifted and transformed into Sankt and Suna. And if you ask about this lacrimation and rhinorrhea and tearing and redness, then you will find that. And in that, adding a little dose of lamotrigine will be very helpful. So my kind of advice would be that that if you are finding that the patients are not responding, then you might add lamotrigine and see that whether the patient responds or not.
So in case like that, we talk about the status of Sankt and Suna. Just a one question I had. This trigeminal neuralgia with the status like thing, have any experience on that? Like so much status like trigeminal neuralgia. Do we have?
Yes.
Hmm.
I would say that, when this actually happens, all these patients of mine actually turned out to be actually a sunk tensona when they present like a status like a thing. So initially there were a lot of levels given as a trigeminal neuralgia, and you know that many of them have their teeth extracted. Another thing, this is very, very important, that if you are finding an isolated V1 distribution, right? So then also you should suspect it, because that is very rare in trigeminal neuralgia. Only about 2 to 3% will have an isolated V1 distribution of trigeminal neuralgia. You should suspect a sunk tensona. And the lamotrigine, if you start, then patient responds very well. So these are the small tricks of the trade you can find. But of course, nowadays with the mobile phones and everything, you can video the attack, and then it can be very informative. There is one question. This is for Dr. Gagandeep, sir. This is that Dr. from Abhishek. Dr. Abhishek, what are the treatment options available for migraine in patients with epilepsy, other than valproate and topiramate? And subpopulation is females of reproductive age group.
Yeah. So the usual treatment of migraine, I guess, would work in people with epilepsy, but yeah, I think it's you need to treat epilepsy, you need to treat migraine, and this very commonly what is often written in some textbooks is that, so you have a patient with migraine and epilepsy, please start the patient on valproate. Please start the patient on topiramate, because the drug works for both the things. So, as every patient with migraine is different, every patient with epilepsy is different, and a patient with epilepsy may or may not respond to valproate or topiramate, right? And likewise, a patient with migraine, and I'm sure Dr. Debashish, this is you would perhaps, I'm not the expert in headache, but you would agree there are some patients who respond to only certain agents and not to all agents. So I think we have to go by the individual situation and take it. Of course, we need to understand that there might be an interaction between epilepsy and migraine, and people being more predisposed due to a number of reasons to the other disorder. But beyond that, I think from the treatment point of view, we need to look at the two things individually. What would be the best way to treat migraine in my patient? If migraine, I mean, there are a significant number of attacks, and what would be the best way to treat epilepsy in my patient? I mean, that is something which I have realized in rather than trying to treat both the disorders with, trying to shoot two ducks with the same bullet is something that I realized does not work often very well.
I completely agree with you, and I think that in these populations where you have a significant two comorbid disorders going together, you should attack each disorder with a specific drug, because if you give a common drug first, you lose that, you don't know that which one is actually getting benefit and which was not getting so much of benefit. And secondly, it is always better to have that specific thing, because epilepsy again is not a single, it's not a homogeneous disease. There's a lot of other types, focal, generalized, then there are types, and you know that certain drugs act better in certain patients. Similarly with migraine, I think. And in fact, this goes also to say that people of migraine and patients with migraine who have a comorbidity like a significant depression or anxiety, it's not just giving an amitriptyline is going to help them, because you have to treat their depression and anxiety if they're severe in a better manner, to give a proper anti-anxiety and anti-depression drug and give something for the migraine. So I think that is very important to understand. And in fact, I had a talk with David also, and David also believes in that. I mean, combining these drugs is better than giving one drug which caters for both the situations.
Yeah.
So I think we are already overdue. We'll take up the questions later if the time permits. Now can I go to the next case? Dr. Ashish, can you introduce the next speaker and the topic?
Yeah, so the next speaker is Dr. Tanushri Chawla. She is a consultant in neurology at Medanta Medicity, and she has done her fellowship in neuromuscular disorders from NIMHANS, also from NIMHANS. So, Dr. Tanushri.
Good evening, everyone. Am I audible?
Yes, Tanushri, please.
Yeah. So, good evening, everyone. At the outset, I would like to thank Dr. Devashish and Ayan for giving me this opportunity. I'll be speaking about Epicrania fugax. It is a new kid on the block and has been recently introduced into the ICHD-3 classification in 2018. So I'll be discussing a few cases and then just generally reviewing this topic. So beginning with some few case scenarios. So this is the case one of a 35-year-old gentleman who presented with 20 days history of daily headaches, hammering in character, lasting for 5 to 10 seconds with a VAS score of around 8. On examination, fundus examination was normal and no neurological deficit was seen. Imaging by MRI was normal. He was treated with amitriptyline 25 mg once daily and responded well with the frequency reducing to once in a month. The pain had a characteristic trajectory which ran from the posteriorly from the right occipital area to the right frontal eminence. Then this is the second case of a 27-year-old gentleman without any history of comorbidities, presenting with 2 years history of, again, daily pinpricking, severe headaches, lasting for a 5 to 10 seconds duration, and had a characteristic trajectory running in the midline from the vertex to the nasion. He had sneezing and bending as aggravating factors, and the pain used to trigger with travel. Again, the no focal neurological deficit or any fundus abnormality was seen in this patient. MRI showed a incidental cisterna magna. This patient was treated with amitriptyline 10 mg once daily and gabapentin 100 mg twice daily, responded well to decrease in the frequency to once in a month and significant decrease in the intensity of the headaches. Case 3 was a 54-year-old gentleman with history of cardiac disorder, presented with 1 month history of electric current-like sensations running from the left parietal eminence up along the inner canthus of the eye, along the maxillary region, up to the angle of the mouth and up to the lower angle of the jaw. He had a variable frequency lasting from 3 to 4 per month up to 5 per day. And again, the imaging was normal and no focal neurological deficit was seen. He was again treated with gabapentin 300 milligram and responded in terms of intensity, it reduced to 3 and the frequency of once in a week. So with this case scenarios in mind, I'll start with the topic that is Epicrania fugax, which was recently described in 2008 by Parija et al. In a case series of 10 patients. And since then, around a total of 116 cases have been described in the literature, as per my knowledge. The age of the onset varies from early 3rd decade to 7th to 8th decade. And across the studies, the female predominance has been seen, ranging from 1.5:1 to 9:1. So the characteristic description is a brief paroxysmal head pain, generally stabbing in quality, with a linear or zigzag trajectory along one hemicranium. The ICHD-3 diagnostic criteria includes recurrent stabbing head pain attack lasting from 1 to 10 seconds and fulfilling the criteria B, that is pain moving with linear or zigzag trajectory along one hemicranium, commencing and terminating in the distributions of different nerves and not better counted by any other ICHD-3 diagnosis. So the pain characteristics are basically, these are painful, ultra brief paroxysmal, generally lasting from 1 to 10 seconds, but up to 30 seconds have also been noted. They're usually spontaneous, but occasionally may be triggered as well. The frequency is quite variable, as we saw in one of our cases. The intensity ranges from moderate to severe intensity headaches, usually described as electric current-like sensations or a stabbing headache, but occasionally has been described as burning or pressing sensation as well. Coming on to the topography, which is the most typical clinical characteristic of this headache. So initially in the case series described by Pareja et al., they described a forward radiation of the brain across one hemicranium. But later on, around 1 year later, Cuadrado et al. Described a similar headache with same clinical characteristics of a brief paroxysmal pain, electric current-like sensations, lasting for 1 to 10 seconds. But the topography was different. That is, the pain radiated from the frontal regions to the occipital regions. So all the other characteristics were the same. And so he described that there could be a backward radiation variant of epicrania fugax as well. Then in 2011, Molero et al. Compared 18 forward radiation epicrania fugax patients versus 9 backward radiation epicrania fugax patients, and found out that they were comparable in all the other characteristics except the difference in the topography. And since then, various trajectories have been described with the typical clinical features of the epicrania fugax headache described earlier. So the trajectories can range from being sagittal to coronal, running from the lower phase upwards, or a facial location traveling either downwards or upwards, extracephalic radiation to ipsilateral limb, neck, shoulder, bilateral zigzag diagonal, both forward and backward radiation in the same patient, and pain spreading along 2 parallel trajectories in the same patient. Commonly, some associated features which have been seen when epicrania fugax headaches are autonomic symptoms, which have been seen to be around at an incidence of 21 to 50% across various studies. They can have ipsilateral conjunctival injection, lacrimation, rhinorrhea, especially more commonly in the forward variant. Cuadrado et al. Found, compared the forward and the backward radiation patients and found out that the frequency of autonomic symptoms was 55.5% in the forward variant versus 33.3% in the backward variant, though the difference was not statistically significant. Apart from that, sensory dysfunction in the form of allodynia, hypoesthesia, or hyperesthesia at the site of origin of the pain may be present. But the characteristic absence of the tenderness over the site of the major nerves like greater occipital, lesser occipital, or supraorbital nerve is important to differentiate it from the neuralgia from headaches like occipital neuralgia. There are reports of epicrania fugax in association with other primary headaches like migrainous and tension type headache. They have also been reported to initiate or precede an attack of migraine with or without aura. They can also trigger linear headaches, which is considered to be a variant of migraine. And nummular headache at the site of origin of epicrania fugax has also been described. Nummular headache, as we all know, is another form of an epicranial headache where the headache is localized over a circular area of around 1 to 6 centimeter over the one hemicranium. 2 cases of reverse epicrania fugax immediately following an atypical cluster have also been described. So epicrania fugax has been described in association with intraaxial structural lesions, though the case reports are limited. There were 3 case reports that I could find in the literature who presented with a symptomatic EF. One was a patient with a cerebellar abscess, which developed 2 weeks after the post-suboccipital craniectomy of an anal Chiari type 1 malformation. This epicrania fugax headache disappeared immediately after the surgery, that is the surgical evacuation of the cerebellar abscess, and the patient was pain-free for the next 12 months on follow-up, according to the report. Then James et al. Also described epicrania fugax-like headache in a patient of post-lateral medullary stroke and responded well to carbazepine. And thirdly, there was a 77-year-old female patient who initially had presented with a trigeminal neuralgia secondary to sphenoid wing meningioma, and she developed a backward epicrania fugax 1 month after being treated with radiotherapy. So, which suggested that the trigeminal pathway may be involved in the pathogenesis of epicrania fugax. So, coming on to the differential diagnosis, which we must keep in mind when we are diagnosing a patient with epicrania fugax. So, the most common differentials are the other epicranial headaches, that is the nummular headache and the primary stabbing headache. And the other close differentials are the Suna and the neuralgiform headaches, that is the occipital neuralgia. So the differentiating feature between epicrania fugax and nummular headache is the typical circular area where the nummular headache is localized, and the headache lasts from minutes to hours in nummular headache, whereas it is a ultra brief pain in epicrania fugax lasting from 1 to 10 seconds in a linear spread or a zigzag spread across one hemicranium. Then primary stabbing headache can have multiple locations in versus the epicrania fugax headache, which is usually in a one hemicranium, and the stereotypical location and linear spread of the pain differentiates it from the primary stabbing headache. Sanct and Suna have a typical unilateral orbital, periorbital, or temporal pain with 100% autonomic symptoms. To differentiate it from epicrania fugax, where we can occasionally see autonomic symptoms, again, the linear trajectory of the pain in epicrania fugax helps us to differentiate between Sanct and Suna is associated with other things like restlessness and other associations. Then occipital neuralgia, to differentiate occipital neuralgia, the tenderness over the emergence of the these greater occipital, lesser occipital nerve or distribution of C2 helps us differentiating epicrania fugax from occipital neuralgias. And of course, the headache lies along the greater occipital, lesser occipital, or third occipital nerve distribution. So coming on to the management, once we have diagnosed a patient with epicrania fugax, we have seen that epicrania fugax is usually a primary disorder and rarely associated with any secondary causes. And once the patient is informed about the benign nature of the syndrome, they often refuse treatment, and preventive treatment is often not required in these patients. Only in patients with frequent, moderately severe headaches, we offer preventive therapy. And across the literature, neuromodulatory therapy in the form of gabapentin, pregabalin, carbamazepine, lamotrigine has been effective. And there are few case reports of amitriptyline, onabotulinum toxin, indomethacin, and local steroid injections also given in epicrania fugax with variable success. So this is a comparison of the various case series describing the epicrania fugax headache, and we can see across the studies that the age of onset ranged from early third decade to up to 70, 83, 82 years, maximum up to 87 years. And usually a female predominance has been seen ranging from 9:1, 12:7. But we recently published a case series of our own under the guidance of Dr. Debashish, and we found a male preponderance. Though there are limited case reports that requires further exploration of any effect of the hormones on the epicrania fugax headache. And we can see that it is usually forward radiation and backward variants are limited and usually described as stabbing, electric, lancinating pains, but burning, pressing type of character has also been described. Autonomic symptoms may be seen, and one of our patients out of the 8 also showed autonomic symptoms. So coming on to the pathogenesis, initially, because of the presence of a trigger zone, electric and stabbing character of the pain, a paroxysmal nature of the pain, and a well-defined radiation, it was thought to be of peripheral in origin. And along with that, it was postulated that it originates from the terminal twigs of supraorbital or greater occipital nerve and spreads along due to ephaptic transmission or paracrine diffusion of chemical mediators or transdiploid transmission. But as the new case reports were generated, and it was seen that with the broadening of the spectrum, that is a sagittal trajectory, extracephalic radiations, coronal radiations, presence of autonomic symptoms, association with other primary headaches, and presence of EF in secondary to parenchymal lesion, it was thought that central mechanisms may also play a role or modulate the peripheral mechanisms in epicrania fugax. So it was thought that the convergence of the cervical and the trigeminal efferents at the trigeminal nucleus caudalis in the upper cervical spinal dorsal horn, that is the trigeminocervical complex, may explain the spread beyond the typical nerve distribution. So coming on to our cases, so one thing which was common and a new thing that we found in these 3 cases was that In each of these cases, the brief headache was followed by a reduced intensity pain lasting for 10 to 20 minutes. And this was after each attack of the epicrania fugax. Similarly, in case 2, it was followed in the same area by a dull aching pain lasting for around 35 to 40 minutes. And it was stereotypical in the form that after every attack, this pain would be persistent for around 35 to 40 minutes. And similarly, in case 3, it was also followed by a dull aching headache of a reduced intensity lasting for 10 to 15 minutes. So when we went back to the literature, we found that in 2014, Wang et al. Had described a entity called linear headache, which is considered to be a variant of migraine and with central mechanisms for its causation. So it is a paroxysmal or chronic fixed head pain in a linear trajectory linking the occipital or occipitalocervical region with ipsilateral nasion or forehead region without the characteristics of epicrania fugax, and it is of long duration, lasting from hours to days, contrary to the R patients. So, but in their case series, they had described 3 patients in whom the duration of headaches was lesser, lasting for around minutes. So, and Parija and Bandaris in 2015 reported a linear pain in one of their patients of epicrania fugax, but in this patient also, this headache was persistent. Contrary to our patients, every attack was followed by a linear headache lasting for a few minutes and then subsiding by itself. And a 39-year-old female was described, followed by linear pain in the same trajectory by Parija and Bandaris. However, this pain was persistent, contrary to our patients, as I mentioned. So this is also different from the intermittent or continuous tenderness or pain stemming from the area from where the EF originates, which may fulfill the criteria for nummular headache. So we had postulated that this epicrania fugax headache in 3 of our patients might have triggered a linear headache. So this was a novel finding in our case series, and we had reported this in one of our papers published in Kephalalgia reports. Thank you.
Thank you. Thank you, Dr. Tanushree, for a very lucid presentation detailing a new entity, which is still included in the appendix criteria. It does not come into the regular criteria, but it is in the appendix criteria of ICSD. So I will invite again some questions from the, from the delegates and from the panel, the faculty. Dr. Gagandeep.
I think it was a very fascinating case, something that I really didn't know about. So it's, for me, it is an absolute absolutely a new learning. So thank you so much, Tanushree, for that. Thank you for that case. I mean, I hope that that's how we learn, and then we go to the clinic and we realize that this patient has this particular type of headache. So knowing is very important. The mind knows what it sees.
Yes, absolutely.
Definitely.
There is a question for you, Dr. Tanushree. There is a question that pneumatized turbinate, can it cause, a headache? I think in the context of your case, epicrania fugax, pneumatized turbinate. I don't really understand what is meant by pneumatized turbinate, but turbinates are
hypertrophy of the
the turbinates are the structures, nasal structures, and there are sinuses which are pneumatized. But of course, so can you find? I think the question might be that did you find that can these mimic like sinus headaches?
They have a very typical characteristic of being very ultra brief compared to the sinus headaches, which can be very non-specific. And sinus headaches actually has to be demonstrated that with a surgical intervention or other intervention that it goes off. Initially, it might be a primary headache because incidentally we can see sinusitis in many of our patients with migraine and tension type headaches as well. So if it
right. So no, I think to answer again would be that typical distribution, the linear distribution starting from one pain area supplied by one set of nerves to the other area, right? From occipital to frontal or frontal to occipital, that actually the typical linear pattern that actually characterizes this kind of a headache. And attack after attack, this, as you said, is stereotyped. It just remains like that. And patient is disabled for that brief moment, but then again it becomes normal. But in 3 patients, we found a relatively longer duration of dull pain that is there. But otherwise, it's a brief paroxysmal electric shock like. And as you said, that in one of the mechanisms, you said it might be trans-diploic. So now there are an increasing amount of literature that is showing that even the cutaneous nerves of the scalp, they actually go in through these trans-diploic spaces, and then they supply the dura and the meninges. So therefore, going into the central system is also possible, as you've shown. So the typical characteristic is a linear, electric shock like. So whereas in sinus headaches, it will be more in and around that sinuses, typical morning features with pressure tenderness around the sinuses. So those things will be there. That will not be there. One question to Dr. Kamakshi, somebody asked about the red ear syndrome in Suna. So, Dr. Kamakshi.
Yes, sir. So this red ear Suna itself is rare. So red ear syndrome in Suna itself is more rare. It is basically manifestation of autonomic dysfunction only in Suna, wherein the patient, along with those headache attacks, get that burning sensation in ear along with this hyperemia of the ear. So pathophysiologically, it is the autonomic dysfunction only with the headache attacks.
Correct.
Yes.
So, I mean, originally this was discussed by Jim Lance from Australia. And actually in his paper, this was described because of a cervical lesion, right? And which causes the autonomic dysfunctions because of, as you said, cervical trigeminal axis, because of this complex there. And the autonomic symptom manifests as a red ear. So it has been described both in migraine, in cluster headache, in other attacks also. So there is not any specificity for that, but it's an interesting syndrome because it stands out because the ear becomes absolutely red and at times painful also. So once, but it's a rare thing. So I have till now I have seen about 4 or 5 cases only. So it's a rare thing, but it can happen in both migraine as well as in trigeminal autonomic surveillance. Okay.
Yeah,
So,
sorry, there is a little bit of disturbance behind this thing, but one thing that helps is ice packs really help in.
Right.
That's my experience in one of the patients with red ear.
Okay. So Dr. Ashish, can you go to the next presentations? This is by Dr. Girish Kulkarni's group. So Ashish,
yes, sir.
Two short presentations from
Two presentations from Dr. Girish's group. So I would like to invite Dr. Girish, and then he can invite the speakers. Dr. Girish.
Anudeep can start, I think.
Okay. Anudeep, okay.
Am I audible, sir?
Yes, you're audible. Please.
Good evening, respected faculty. My name is Anudeep. I'm currently doing my senior residency at Nimmans Hospital. Today, I'm going to present a case under guidance of Dr. Girish, sir. So, presently, thanks to the forum for giving an opportunity to present a case. So, this is a story of about a 30-year-old gentleman from Tamil Nadu who is working as an employee in a private institute. He presented to us with complaints of headache since August 2021. So in August 2021, it started with bifrontal headache, which was dull aching, grade 3 to 4 out of 10 severity, which was continuous but present only for 3 days, and it actually spontaneously. He was headache free till November 2021. Again, he had similar headache with almost same severity, but this time he required treatment at outside hospital, and it subsided after 3 days. Then till July, he was again headache free. Then this time he had a right hemicranial headache, which was very severe, around VAS 8 to 9 out of 10 severity, which lasted for about 3 to 4 hours duration. Sometimes associated vomitings was present. Headaches was present daily for about 15 to 20 days in the month of July and August. In September, the headache even worsened in that the form that it has become continuous and daily headache and multiple episodes during the day, each lasting for more than 4 hours. There is no history of any aura, photophobia, phonophobia, no history of any autonomic symptoms, no history of transient visual obscurations, tinnitus, postural variation of symptoms, no history of fever or any systemic symptoms, no history suggestive of any connective tissue disorder. So treatment history, he was initially, he was followed at an outside center. In November 2021, he was given a short course of flunarizine and amitriptyline and sodium valproate for about 2 months, later which he stopped. Again, in July 2022, he was admitted in outside hospital when he had that severe right hemicranial headache. He was treated as meningitis with ceftriaxone, linezolid, ofloxacin, and acyclovir. We thought of an episodic headache to start with, which evolved into an sidelock lateralized chronic daily headache of more than 4 hours duration. So etiology, we thought whether it is a primary headache or to rule out the secondary causes of the headache. So on examination, his BMI was 32 kg per meter square. Rest of the general examination, other system examination was unremarkable. Neurological examination, visual acuity was 6/6 and fundus was also normal. Essentially, and normal examination was there. So this patient to discuss what is chronic daily headache, it is nothing but presence of an headache for more than 15 days per month for longer than 3 months. And this patient also had a side-locked headache, which means that headache is always coming on one side. According to Leon et al., he suggested that at least 90% of the headaches are on one side. And this chronic daily headache can be approached as less than 4 hours duration or more than 4 hours duration. And usually, most of the times, it is a primary headache. That is, two-thirds of the cases have primary headaches, but it is important to look for the secondary headaches. So chronic daily headache comes as more than 4 hours or less than 4 hours. So the common etiology for more than 4 hours duration is chronic migraine, chronic tension type, other being medication overuse headache, hemicrania continua, and new daily persistent headache. When the same chronic daily headache is for less than 4 hours duration, it is a TACs which dominate in this group. That is a chronic cluster, chronic paroxysmal hemicrania, Sankt Suna, and other causes to be looked for is the hypnic headache and primary stabbing headache. So in such cases, importance is that to look for the red flags. Because it's easy to label as a primary headache and as examination is also normal. So specifically, we need to look for the red flags, like is the patient having any systemic symptoms or whether the headache is sudden onset and usually after 50 years is a red flag, and persistent and progressive headache. And patients with neurological manifestations in the form of cranial nerve palsies, cognitive motor dysfunction, all are red flags. So in our patient, he's a young patient, but fairly new onset headache, and he had a persistent and progressive headache, and which was not responding well to medication. So these were the red flags in this patient. So if you see, the primary side-locked headaches includes most of the causes are migraine and TACs, the other being hemicrania continua, NDPH, pneumolar headache, and epicranial fugax. But important is not to miss the secondary side-locked headaches, which includes cranial or cervical vascular disorders like dissection or CVTs, or a non-vascular intracranial pathology, and other being the neuralgias and other headaches. So we shouldn't miss the secondary causes of the side-locked headaches. So there is a good paper in published by Prakashas in et al. In Journal of Headache and Pain, in which there is an algorithmic approach to the side-locked headache. In that, importance is to the detailed and comprehensive history, and then to look for the red flag signs. If they are present, then work up for the secondary headaches. If they are not present, then we can try to treat as a primary headache, but look if the patient is responding or if he is developing any red flags, he needs to be evaluated further. So in the same article, he has there is a detailed description of how to go about it. So in that, importance is to the identification of the risk factors, such as the demographic risk factors can help us. That is age, usually more than 50 years. Think of temporal arteritis, malignancy, and prothrombotic states like pregnancy, postpartum, alcoholic, etc. keep in mind about CVT, as well as any neck trauma or in spinal manipulation, arterial dissection needs to be kept in mind. Then look where is the site of the pain and determine the onset, whether it is acute, subacute, or any chronic, and associated symptoms like whether orbital pain is there or whether any autonomic features are there, and any provocative measures are there. So in coming to our patient, he was further worked up. His routine investigations like CBC, LFT, RFT, electrolytes were normal. ESR was 22 millimeters per hour. Thyroid profile was normal. His RA factor, ANA profile, ANCA, and VDRL were negative. Serum IgG4 levels and ACE levels were normal. Schimmer's and pathogen test was normal. His CSF was showing an opening pressure of 170 with 14 cells, predominantly of lymphocytes, and protein was mildly elevated, and glucose was normal. His CSF, CBNet, VDRL was negative, and HRCT was normal. So this is the MRI which was done at outside center during the recent episode of headache when I had worsening, which is showing an axial section of the brain T2 flare. Both supratentorium and infratentorium is non-contributory. The same patient, when given as a contrast, we can see there is an thickened right tentorium cerebelli and also the inferior and superior cerebellar foliar surface. So this patient we diagnosed as an hypertrophic pachymeningitis. So coming to the what does the literature tell about this is it was first described by Charcot in 1873. It is nothing but inflammatory process which causes localized or diffuse thickening of dura mater. Again, it can be primary, which is or idiopathic, or secondary causes are there. So coming to prevalence study, as such from India, there is no prevalence study, but many case series are given there. But from a nationwide survey in Japan, which was done between 2005 to 9, showed about 159 cases in which idiopathic formed the major bulk of the cases, followed by Wegener's and IgG4 related disease. And other recent study, which was published from southern Chinese population, showed had about 48 cases. Again, the bulk of the cases was idiopathic, followed by Wegener's and tuberculosis. So they can present with varied manifestations, that is headache, cranial nerve involvement, gait ataxia, seizures, cognitive impairment. Even the thickened meninges can encase the venous sinuses and can cause the cerebral venous thrombosis also. And headache is the most common manifestation, and it is present in about 80 to 90% of the cases. And according to a study done by Wang et al., it is a chronic daily headache by which they present, especially the chronic migraine type was the most common headache pattern. And other studies have shown that the lateralization of the headache appeared in more correlation of the site of the dural thickening. So there is a huge number of causes which we need to think when we are seeing an hypertrophic pachymeningitis. It is important to investigate for them. The common subheadings, important subheadings being inflammatory, infections, and neoplastic. Inflammatory, it is the IgG4 disease which has come up more in this recent years. Other being Wegener's granulomatosis, sarcoidosis, RA, and SLE and Behçet's needs to be kept in mind. Infections, again, tuberculosis, syphilis forms important differentials, and neoplastic like lymphomas, carcinomatous meningitis also needs to be considered. And other causes, intracranial hypotension, spontaneous or whether it is an surgical or iatrogenic, who present with clinically with an orthostatic headache and has a classic diffuse pachymeningeal enhancement. So aim is to rule out secondary causes, and CSF usually shows lymphocytes with raised protein levels in almost all the diseases. And biopsy is done to establish the diagnosis and mostly to rule out the other inflammatory causes. And if you see the imaging, it is there are some imaging features which can help. What we need to look is whether it is a diffuse enhancement or a localized enhancement, whether it is a linear or a nodular enhancement. So if we see in that, and there is a location if it is focal. So posterior fossa is commonly affected in case of idiopathic and tuberculous meningitis related hypertrophic pachymeningitis, whereas frontal, parietal, and occipital lobes are most commonly affected in Wegener's. and it is usually diffuse in case of Wegener's and idiopathic, whereas a focal in case of tuberculous meningitis. And coming to the management options, there are no definite guidelines on how to manage such cases, but commonly used first-line therapy will be steroids. There are some case reports with IV methylprednisolone or as well as oral steroids, and there were no head-on trials. I couldn't see any such articles, but usually, but whatever the case reports and case series have given data that usually they are very well steroid responsive, but there is a high chance of recurrence once we start the tapering of oral steroids and IV steroids, and hence many groups have tried to use long-term immunomodulation like methotrexate, azathioprine, etc. in such cases. And recently this rituximab has also been tried as an option in case of this hypertrophic pachymeningitis. And in the article in 2017, which was published, actually has seen that, or it was around the case series of 3 patients, which has seen about the improvement of the patient post rituximab, and also there was clinical imaging improvement was also there in the form of reduced thickness. So for this patient, what we have decided is to give an initial 3 days of pulse methylprednisolone, followed by continuation of oral steroids. We have discussed regarding the patient, regarding he may develop few further symptoms in the follow-up, and if in case in that is the scenario, we are planning to do an biopsy. Since now he is not having only headache and no cranial nerve manifestations or other manifestations, we thought of giving an steroids first as the initial management, and we would like to follow up the patient. And we are also thinking of keeping the diagnosis open, because in follow-up, initially the workup may be negative, but in the follow-up he may be diagnosed as other manifestations, other causes of hypertrophic pachymeningitis also. So the idea of this presentation is to give an overall approach of chronic daily headache. So to know the causes, common causes of less than 4 hours duration versus more than 4 hours duration. And many times examination may not help us in chronic daily headaches, but it is important to look for it, and which may help us to change our thought process. And always look for red flags and think of secondary causes, especially in medically refractory chronic daily headaches. And if a normal imaging may not pick this, as we have seen in our case, but it is a contrast imaging which is required for the diagnosis, and hence it would help us in the management of such cases. Thank you.
Thank you. Thank you, Dr. Anudip, for a very nice presentation. And before I open it to the comments and question answers from the delegates, I would just make a few more comments. One is this, that a recent chronification, a short lasting chronification is about 3 months, within 6 months, is a red flag by itself. If the patient was having, episodic headaches and now it has recently chronified, so that itself is a red flag. So that those patients must be imaged, even if the phenotype is either a migraine or a tension type. So that is number 1 point. Number 2 point, in such patients, when you investigate by neuroimaging, you must do a contrast, because as shown by you, you can find a lot of findings on contrast. So I see a lot of patients being investigated with just an MRI, but they don't do the contrast, because if you don't do the contrast, you'll miss out this meningeal involvement. In fact, some of the patients may also be having say something like spontaneous intracranial hypotension. That can also present as a chronic daily headache, and that will be completely missed if you don't do the contrast examination. Number 2. Number 3 is this, that in your case, although IgG level, IgG4, when you flash that, I knew that you were talking about hypertrophic pachymeningitis, because that would otherwise be out of context. But that level is not very reliable in discriminating between those who have it or those. If it's positive, then it's important, but if it's negative, it doesn't rule out the presence of IgG4. So I think in those cases, probably a biopsy would be a better choice if the patient is symptomatic enough. 4th thing is this, in our setting, we have seen a lot of patients of sarcoid and tubercular also presenting like that. So we need to exclude that diligently also. So with these caveats in mind, yes, of course, chronic daily headaches would, they do pose a challenge, and sometimes they may be very difficult to diagnose. Dr. Gagani, please.
I think you've said it all. But any change in nature of the headache, change in the frequency, chronification, recent onset, just like Dr. Devashi said. So that should always be a red flag, and we should try and find out why that has happened, and we need to investigate that kind of situation. Yeah, the other thing is about biopsy. Biopsy often is difficult, and but wherever possible, we try to get tissues for the biopsy. The serum IgG4 levels are not very reliable. I'm just echoing what Debashi said.
Right.
But that was a
Sir,
good presentation.
good evening, sir.
Congratulations.
I am Dr. Giri, sir. Sir, thank you for an opportunity. Actually, here one headache conference was going on. It went beyond the time. That's why I couldn't join immediately, sir. Sir, what we wanted to highlight from this case is that points mentioned. The only thing I wanted to add is the biopsy, sir. Many times we have done, and it is non-specific granulomatous. It will come, sir. Unless then we reviewed the whole literature. Then what we found is if patient is not responding to the initial steroid and he continues to worsen and new symptoms develop, then definitely we should undertake the biopsy. That's what is the consensus, but clear-cut things are not there. That's why we didn't do the biopsy. Thank you.
Yes, I agree with you that biopsy is not likely to be taken. But only thing is that if you want a definitive diagnosis, then possibly that is indicated. Exactly. I mean, in day-to-day working, it might not be of this thing, but anyway, because you are giving steroids, and IgG4 also you will be giving steroids. But overall prognostication and the definitive diagnosis possibly will require a biopsy if the levels are not high. The levels are very high, and you know that the clinical context. So we are seeing a lot of this hypertrophic meningitis in the cavernous sinus, in the overall, meningeal system, and some of them are coming as very high IgG4. So that is also true that if positive, but if negative, then the chances. So there is one question from a doctor here that he is asking: does the CSF picture does not simulate viral meningitis, Dr. Anudeep?
Yes, sir. Actually, there will be like cells will be very mildly elevated, and there will be mild elevation of proteins. But anyways, clinical picture usually doesn't think of any viral meningitis. But CSF may be similar to viral picture, sir.
Yeah, so it has been there for some time now.
Clinical picture
Normally
is
viral
completely
meningitis.
different, actually. No?
Yeah. So that
cell count up to 200, they have been described, sir, in pachymeningitis and elevated protein, sir. And few of the patients, it may be totally normal also. But overall, the clinical picture and the MRI features will make us more of think of this rather than the viral meningitis or encephalitis, sir.
So one another question is this, that do you consider in our setting, in India setting, when you are adding steroids and you are seeing some cells and proteins are raised, so would you empirically also add an ATT in the regimen?
Actually, other cases which we have seen, sir, we are usually adding ATT when any other clues we are getting, like any lung infection or imaging wise also any extra clue we are getting, we are actually adding. In this patient, we thought we will initially wait for like how does he do, and follow up interval MRI we will do, and then we would take a call for empirical ATT, sir.
Yes, I think that's a reasonable choice, and especially if you do Mantu and all that, and also if you search out for all the tubercular focus elsewhere, you will probably be reasonably certain, not 100% certain, that you are probably not missing a tubercular case, and you can add the steroids. There will be some risk involved. You have to explain to the patients, and then I think you can start, because if you combine both, then you will lose out the marker, and you will not know that whether this was really tubercular or not. So I agree with you.
Sir, one more thing, like as you told, two of my patients, sir, when we started like this combined, initially I was giving like this. developed hepatitis, sir. Then it becomes very difficult. We don't have a clue, and patient relatives will ask us on what basis ATT was started. And sir, we have a renal failure,
Correct.
we can manage. But hepatitis managing, I have gone through those two patients, very difficult and demanding, sir. That's the reason I have not stopped giving ATT presumptively, unless, as Anudeep told, there is a lung marker or ESR is very high. There is a contact with TB in the family, something which makes me to believe that I should give the ATT.
Correct. Okay. So thank you very much, Dr. Anudeep. Can I go to the next case, please, Dr. Ashish?
Yeah, so next case will be by Dr. Suhas. Dr. Suhas, please.
Dr. Shwas, could you share your screen, please?
Just a second, sir. So is it visible, sir?
No, not yet.
Green is not visible.
Dr. Ashish, is there any problem?
Sir, he's probably not able to share his screen. Dr. Suhas.
Hello. Hello.
Yes.
Hello. Dr. Suhas?
He has muted himself. Dr. Suhas, can you unmute yourself?
Unmuting, sir.
Yeah.
Sir, you can click on share. The
Okay.
green icon.
Yeah.
Hello.
You're probably using the same.
Yeah.
So, okay.
New share.
So put it on slideshow mode and you can start.
Unmute video.
Yeah. Start, please.
Okay. I am Dr. Suhas. I will be presenting solving the mystery of long-standing headache and vomiting under guidance of Dr. Girish, sir. So we have a 35-year-old lady from West Bengal who presented with complaints of headache and recurrent vomiting since past 8 years. Patient was apparently all right 8 years back. Patient conceived, and during a second month of a gestation, she started to have headache. It was holocranial, moderate in intensity, with a VAS score of 6 to 7. It was associated with the photophobia and phonophobia as well. And she would say that the headache would last till she took analgesic medication, and she also had sleep benefit. There was no history of any aura, and it was triggered by traveling, loud sound, anger, and also with stress. The frequency of headache was around 2 to 3 days per week for the initial 4 years, and thereafter it was 3 to 4 days in a month, and intensity had remained the same. And since 8 years, patient also has recurrent episodes of vomiting. It is non-projectile type, it is associated with nausea, and it contained food particle, and it increases after taking heavy meal. During each episode of headache, patient has vomiting at the peak intensity, following which headache would reduce to some extent. But every episode of headache is not associated with, every episode of vomiting is not associated with headache. And coming to frequency of vomiting, for the initial 4 years, the frequency was around 3 to 4 per week. And for the next 2 years, the frequency was around 5 to 6 per week. And in the recent 2 years, daily she has been having 2 to 3 episodes of vomiting. And there is no specific periodicity or no specific timing for this vomiting. And other negative history, there is no history of seizures, no other cranial nerve symptoms, no history of weakness, sensory or bowel and bladder symptoms. Or then there is no history of pain abdomen or constipation. No history suggestive of any psychiatric illness too. And she also has unintentional weight loss of around 5 kgs in past 2 years. And past history wise, she has history of miscarriage 1 year back, and she consumes a vegetarian diet, or still she has a good appetite, and she has no habits or addictions. Previous treatment history, she was treated with escitalopram, fluoxetine, and amitriptyline, proton pump inhibitors, NSAIDs across different timelines, details of which are not clearly available, and she had partial relief of symptoms with these medications. On examination, vitals was stable and BMI was 20.3. CNS examination, including fundus and visual acuity, was normal, and other system examination was also within normal limit. We had asked her to maintain the headache diary. She used to have headache almost every day when she came here, and she also used to get vomiting of around 2 to 3 episodes per day. And to summarize, she's a 35-year-old lady with known comorbidities, presented with history of 8 years history of chronic headache and recurrent vomiting. And we consider possibility of neurological versus non-neurological causes. Our differentials initially were migraine, cyclical vomiting syndrome, area prostativa syndrome, metabolic or other gastrointestinal causes. Considering the above differential diagnosis, we went on to investigate for the causes. Investigations included biochemistry-wise RBS, RFT, LFT, TFT, electrolytes, HbA1c, ammonia lactate, and phosphorus, urine, porphobilinogen, serum blood, and fasting cortisols were all within normal limit. And pathological investigation included CBC, peripheral smear, and ESR was normal. To rule out autoimmune causes, we did ANA profile, ANCA, NMO, and MOG, which were negative. And imaging-wise, MRI brain with MRV and ultrasound abdomen pelvis was normal. Upper G endoscopy and colonoscopy was within normal limit, and cardiac evaluation was also normal. So coming to analyzing this case, can a patient with migraine have vomiting without headache? So if you see the pathophysiology of migraine, it's because of cortical spreading depression that occurs at the level of cortex, and this resulting in migraine aura and cognitive symptoms. At the level of thalamus, there is sensitization and alteration of thalamocortical circuits, and hypothalamus plays a role in activation of premonitory phase. And at the level of trigeminal-cervical complex, there is release of CGRP and PSEP, which results in headache and other symptoms as well. And if you see pathophysiology of vomiting can be because of CNS cause, it can be because of vestibular, or it can be because of GI causes. There are multiple peptides and hormones that are implicated in the pathophysiology, which includes neurokinin, GABA, dopamine, and from GI tract there are again 5-hydroxytryptamine, neurokinin, and other other neurochemicals. So if you see ICSD-3 criteria for migraine without ARA, patient should have at least 5 attacks, and headache should last for 4 to 72 hours when untreated or treated unsuccessfully. And headache has at least 2 of the following characters: unilateral in location, pulsatile quality, moderate to severe intensity of pain, aggravated by or causing avoidance of routine physical activity. During headache, at least one of the following, that is nausea, vomiting, photophobia, and phonophobia should be present, and it should not be accounted by any other diagnosis. So we went on to review the literatures to look for the causes where we could find isolated vomiting, which was not every time associated with headache. Here we found few cases where this was a series of 3 cases. They have reported headache. They were having vomiting in isolation without presence of headache too. And these 3 cases, few of a patient was diagnosed to have cyclical vomiting syndrome, others with migraine, and they were successfully managed with amitriptyline, considered them as migraine, and they were treated successfully. Can our patient have cyclical vomiting syndrome? there is a concept called brain-gut connection. So alteration in serotonergic signaling and autonomic dysfunction can result in few of the disorders, such as functional dyspepsia, gastroparesis, migraine, and cyclical vomiting syndrome. So if you look at the Rome 4 diagnostic criteria of cyclical vomiting, so there should be stereotypical episodes of vomiting regarding onset that should be acute and duration less than 1 week, and at least three discrete episodes in the prior year and 2 episodes in the past 6 months occurring at least 1 week apart, and absence of vomiting between episodes, but other milder symptoms can be present between cycles. And supporting criteria wise, personal or family history of migraine headache. So why not is it a case of cyclical vomiting syndrome? So in our case, there was lack of periodicity, and there was also lack of symptom-free interval, which can makes cyclical vomiting syndrome unlikely. If we look at other possibilities, again, area prostema syndrome, there are multiple reports where patients with NMO, and it's also included in the diagnostic criteria of NMO as well. So presenting with persistent vomiting. So again, we went on evaluating, we found that MRI brain was normal, ruling out structural causes as well as demyelination, and serum NMO MOG antibody panel is also negative. And what about gastrointestinal causes? Again, there are multitude of causes which can cause persistent vomiting, and these include mucosal causes, mechanical obstruction, hepatobiliary, motility disorder, and gastroduodenal as well as functional causes. So patient was actually previously evaluated thoroughly within Asian Institute of Gastroenterology for most of these GI causes with endoscopy, colonoscopy, as well as ultrasound abdomen, ruling out most of these causes. So what's the most likely diagnosis? So diagnosis is actually open it, but considering the clinical features and when we went through few of the case reports, we considered probably it could be a migraine. And how did we manage? Initially, she was managed symptomatically with antiemetics and analgesics. And patient was started on amitriptyline, riboflavin, and topiramate as prophylactic anti-migraine medication. And references were taken from Department of Psychiatry to rule out psychogenous causes like bulimia, OCD causing persistent vomiting, and also to rule out other stressors. And again, we took a official gastroenterologist opinion to rule out GI causes. Did she respond? Patient had reduction in frequency of vomiting and headache severity as well. And currently our plan is to continue above medications for 2 more months and to monitor her with headache and vomiting diary. And we would like to again review the diagnosis, and we would like to work up further based on the further symptoms. And currently when we asked her to share her headache diary and vomiting diary, we found that headache has significantly reduced, and as well as she has had only 1 episode of vomiting in the last 3 days, which was present almost daily for past around 8 years. So take home message, migraine can present with vivid manifestations, and as there is no specific imaging or any other investigation that can actually prove it as migraine, it is better to give a trial of anti-migraine to look for a therapeutic response and can help in establishing diagnosis retrospectively as well. And other condition like demyelinating disorder like NMO MOG can present with persisting vomiting. And I would like to take this an opportunity to take input from audience and senior faculties as the diagnosis is yet open.
Thank you, Suhas. As Suhas told, it was a very challenging patient for us, whole family with us, telling that, sir, we can't do anything. The whole family is disrupted because of my daughter-in-law's vomiting. And so much investigation, so much treatment, and no diagnostic things. And gastroenterologist told they showed the patient that it is your head. You have something, whether neurological or psychiatry, you go to some place. So finally, they decided to come to NIMHANS. And the main reason is not to tell that we are correct or wrong or something. We want the opinion from the senior faculty and their opinion also. What else we should do for this type of patient? Thank you.
Thank you, Girish, for a very nice case and thought-provoking case. I think, we tend to see these cases only in the tertiary care centers when they fail their primary and secondary cares, and even sometimes to the general neurology care, right? So we do see this in tertiary care headache centers. Now, there are few things which I'd like to point out. First thing is this, that you should first, clearly define the headache syndrome. Unfortunately, in the presentation, I didn't find that clear delineation of the headache syndrome. It looks to me as a chronic migraine, right? But you should define it. You should define it clearly, that how many days in a month, how many days of migrainous characters, how many days without migrainous characters, what are the characteristics in that, associated symptoms in that. So that should be very clearly defined. Because you see that in chronic migraine patients, what happens is this, that besides the headache part, because of this increased sensitization, many of these other associated central symptoms like nausea, vomiting, photophobia, phonophobia, they decrease in intensity in some of the days, or may become the sole manifestation in some of the days. So sometimes, in fact, in your presentation, I think vomiting is highlighted, but nausea part has not been highlighted so well. I think you should take the history of nausea also. And in fact, as you may be aware, that nowadays in both the acute treatment paradigms and the preventive treatment paradigms, the one aspect that is seen clearly is the most bothersome symptoms in addition to headache, right? That can be nausea, that can be vomiting, that can be photophobia, that can be phonophobia, that can be osmophobia, right? So these can bother the patients more than the headache, as in happened in your case, that probably the vomiting was bothering them much more than the headache, right? That is one part, right? So that therefore you should be very clear that how much nausea, because the studies have shown that the prevalence of nausea is much more than the prevalence of vomiting. Nausea happens to about almost like 50% of the patients, right? Whereas vomiting happens to about 20% of the patients. So nausea is an important component. So you should not neglect that in that. So from my point of view, it does look like a chronic migraine with a kind of a predisposition to this non-headache symptoms also, right? That is one part of my comments. The second part is that when you talk about the cyclic vomiting syndrome, this is actually clearly delineated in ICSD-3 as a childhood periodic syndrome, under the group of childhood periodic syndrome. Most of these patients will have this initially as a childhood syndrome and later on go to develop a kind of a headache, which is migrainous phenotype, right? So therefore, in adults, you will rarely find until unless the migraine has really chronified to an extent that it behaves like your patient, and then there are kind of, at times the patient will have nausea, at times the patient will have vomiting, and this might give us a idea that it is a pseudo periodic kind of a pattern, a pseudo cyclical pattern, which you have seen in your case. So that is important. You have said about the Rome criteria, but you should also refer to the ICSD criteria for cyclic vomiting syndrome. This is given there, right? Okay. And the third thing is this, that many a times here, you might consider, like you have given the anti-migraine drugs, so you might actually need to intensify many a times the treatment for this, and you have to give a drug which is less gastric irritant or this thing, because they have a kind of a this predisposition. So that might also be an important point to consider while giving you the. So these are my few comments. Dr. Gagandeep Singh, you would like to comment on this?
Yes, I agree. I mean, cyclic vomiting, although classically seen in children, but it can occur in adults. The usual trajectory is that during childhood, they have cyclic vomiting, and then as they graduate into adulthood, they often have the typical migraines. The cyclicity was missing. I wonder if, sorry, I might have missed it, but was a psychiatric workup done in this particular patient?
Yes, they have done.
Yes, sir. Done, sir.
And that did not disclose much.
Sir, actually, we recorded the vomiting event also to see whole thing, but because of the privacy, we are not shown, sir. It is a correct vomiting only, not regurgitation or gastroparesis like thing. It was very this thing that husband recorded the whole vomiting thing also. And the
Are there any
psychiatrist also.
provocative factors for the vomiting? I mean, did it occur in any particular situation or?
Food intake, sir. The food intake was the most important provocating thing.
So, this chronic migraine patients, they can have a persistent nausea, persistent, sense of nausea and, occasional or regular vomitings. I've seen, a lot of patients like that. But in a case, your case is pretty long, 8 years, because probably the people who were treating them earlier were not that much concerned with the headache part. Probably they centered more their attention to the vomiting part. That might be, an important consideration. So I see some questions here. So one is that, is cyclic vomiting a variant of pediatric migraine? Yes, as I said, that it usually comes under the childhood syndromes, but it can happen occasionally in adults also. But then I think it needs to be, he has given all the differentials that is possible. Another important question was that, was EEG been done? Can it be something to do with ictal kind of a thing?
No, sir, we didn't consider, sir.
Yeah, it's very unlikely. I'm not sure. I don't think. I mean, the history. How would EEG really help? I'm not sure. Okay. Yeah, it is a difficult case. I'm just wondering if there were any psychogenic elements which were super added. You should always suspect of psychogenic vomiting.
Yes.
Someone who is, of this age, for less than 40 years of age, recurrent, and it can be a very difficult diagnosis to make. Usually the vomiting is provoked by certain situations in that. That is the key thing.
Yes, sir. It was very much considered, sir. Actually, I sat separately with mother-in-law and the patient. The only thing is she wanted to work outside, and that family things were that she has to be in the house. So that's the thing. But the psychiatrists, they are very good in eliciting and correlating, sir. They tried, they told it is not related. That's what they told.
Yeah, I mean, sometimes it runs deep inside and you really, but since you have taken out a good psychiatric opinion and demands, you have a psychiatric support. So I think that they must have investigated and seen from all angles. And another thing, Suhas, which you made a comment like, that there is no diagnostic test for migraine and therefore it is open. Although there is no diagnostic test, but there are defined operational criteria as given by ICSD-3. So we tend to diagnose migraine, chronic migraine according to. So, giving this impression that migraine is an imprecise diagnosis is not correct. Migraine has, and that criteria has had a validity and reliability, very good high rater inter-rater, variability results, so that we can diagnose with reasonable certainty, provided we rule out all other secondary causes, as this is migraine or a chronic migraine. So we should not give this impression that it is just a kind of migraine is just a diagnosis which cannot be made or which is made based on just some clinical assumptions. These are robust operational criteria. Thank you so much. I think there is one question for Tanushree that somebody has asked later, that when occurring with other primary headaches like migraine, do you need to treat epicrania fugax separately, or they respond usually to the migraine headaches?
Actually, if some of the drugs which are effective in migraine and because of the central causation as the mechanism in epicrania fugax as well, so some of the drugs like amitriptyline, GON blocks, or onabotulinum toxin can be considered, and targeting migraine first. And if it is mainly the centrally predominant mechanisms, it should respond. And if it is still not responding and the migrainous phenotype has subsided, maybe we can consider the other neuromodulatory therapies like gabapentin and pregabalin in addition, if the epicrania fugax is still persisting in that patient despite the other therapies.
Correct. And two other questions which are not particularly related to the case presentations that happened today. One is a headache in POTS, the postural tachycardia syndrome. Dr. Kamakshi, can you enlighten us? And Dr. Ashish, can you enlighten us on this?
Yes, sir. So in postural orthostatic tachycardia syndrome, patients can present with headache. We have seen patients who have, other than the postural symptoms of because of tachycardia, they can have headache. And because of the comorbid tension type headache or a comorbid migraine, also they can have headache. And even patients with orthostatic hypotension can have a headache and a coat hanger type of distribution of pain. So, in fact, if a patient has a postural type of headache, and one should obviously rule out a POTS syndrome in that by measuring the pulse rate in a lying down position and a standing position.
Correct. So I think the patient population, you should also define the young females.
Yeah,
they are
young
usually they are actually
young females, and mostly it starts after some sort of a viral prodrome. And
so another question is that about the headache due to contrast encephalopathy. So, Dr. Kamakshi, Dr. Gagandeep, do you have any experience on that?
I guess contrast encephalopathy more than this vasomotor dysfunction which occurs in contrast encephalopathy. Headache is a part of the spectrum of the abnormalities which occur in contrast encephalopathy. The patient is encephalopathic, some sort of cortical dysfunctions, and headache is a part of all these disorders. Rather than defining the symptomatology.
I think someone's video is or audio is at the background working. I don't know. Kindly stop that. Yeah, continue, please.
So it's a part of the broader spectrum of the neurological dysfunction which occurs per se due to the contrast encephalopathy, majorly as a part of vasomotor dysfunction, and particular headache phenotypes, I guess they have not been defined as a part of contrast encephalopathy per se. It occurs as a part of broader spectrum of neurological dysfunctions, including the encephalopathic features and this.
Correct. So it will come under a secondary, kind of cause of headache due to drugs or toxins, under that will come.
I would like to add that the temporal relationship with these disorders is more important, and the resolution of the symptoms with the resolution of with the treatment of these disorders will tell us whether the headache was primarily associated with the underlying condition or it was a primary headache altogether.
Correct. And there is another question is that to Dr. Tanushree is that how do you manage this infrequent epicrania fugax patients who are just having, say, once in 3 months or twice in 3 months, but they are severe enough to need admissions for these episodes?
Maybe gone block can help in these patients during those attacks, as gone block has been tried in these patients of epicrania fugax. And if they are infrequent and not severe, then just counseling the patient will work. But if they are severe, then gone block or maybe an alternative to that, to a treatment, as a treatment.
Right. And I think we have done, one is again a question for Kamakshi. What is the role of DBS? Because nowadays neurologists are all excited about DBS, especially our movement disorder colleagues. So what is the role of DBS in SUNCT and SUNA?
Yes, sir. As we have already discussed, this part of the short-lasting headache, we should obviously try to medically optimize the patients. And the patients who actually need a surgical intervention, probably they would be a very rare chunk. Secondly, as we all know that the posterior hypothalamic gray matter is at fault in these disorders. Patients who have been resistant to the therapies have been tried on hypothalamic DBS and have been found to respond to the therapies. But still, having said that, medical optimization is the treatment for these cases.
Yes, I think the evidence, the Leone group from Italy has actually started doing that in refractory cluster headache patients. And they initially performed some, and then there is a data. But then there were complications, because one problem is this: even when say that is a posterior hypothalamic area, we are not able to define exactly the target. Which area in the posterior hypothalamus would be the target. So, and there have been at least 2 or 3 cases of bleed, and one of the patients probably died also. So this has generally been reserved in extremely severe cases, refractory cases. Nothing is happening, nothing is being done. So, and now with the advent of monoclonal antibodies, again, a new vistas have opened up for treating the refractory ones. So I think that the DBS would be kind of a very, very last option for these patients. And I think there are only a handful of cases where SUNT and chronic SUNT and SUNA patients have been tried on DBS. So I think we are end of our time, and I think we are end of our questions. Most of the questions I think I have addressed too. And I thank you all the speakers for presenting excellent cases. And I thank Professor Gagandeep Singh, the President of Indian Academy of Neurology, for being with us for this session, and all the delegates who have joined us. I see that about 40 plus people joined the webinar. So it's a very encouraging sign despite the webinar fatigue. And I think that this will continue with this 2 monthly headache subsection webinars, and Dr. Ashish Duggal is organizing it. So thank you, Ashish. And I think we hope to see very interesting cases throughout India. And as you can see that we are now trying to give more opportunities to youngsters, the younger IN members to actively participate and come forward. And Dr. Gagandeep Singh will agree with me that this is our motto, and we should actually be more inclusive to younger generation of neurologists. Dr. Gagandeep Singh, please. Dr. Gagandeep Singh, your comments, please. I think you were muted. Please unmute yourself.
I'm sorry, there is some kind of function which is going next door, and I actually cannot hear anything. So I'm extremely sorry. I've really enjoyed it, and extremely, I was absolutely delighted. But if you can probably hear the background music, you will just understand that I've not been able to catch up the last minutes.
I was just saying that it was so heartening to see the youngsters coming up, youngsters. Right. So thank you, everybody. Thank you so much. So we are finishing on time, and thank you, the digital team, and see you after in January. Thank you so much. Bye-bye.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir. Thank you.
Thank you.